the incidence of these cancers is increasing. So that's the first thing to say. So the age-adjusted annual incidence is increasing year in, year out, and that's not just in Europe, but in America as well. And the main reason for that is because our diagnostics are improving rather than the cancer itself increasing in incidence. And the other thing to say before I even start the talk is that the survival of all these neuroendocrine tumours are improving year in, year out, especially the GI nets and the pancreatic nets. And that's not because the lung nets aren't moving along, it's because the research focus is mainly in the GI nets and the pancreatic nets. And largely this talk has a political steer from my point of view to you guys, because I think there's a particular use that we can have symbiotically for each other in this. And so as I give the talk, you'll realize what I mean. So in terms of the scope of the talk, I'm going to talk specifically about the typical and the atypical neuroendocrine tumours, not the poorly differentiated cancer, the small cells and the large cells. And I'll explain what these are in a second. So the mean age of the typical and the atypical neuroendocrine tumours, they occur in the 4th to 6th decades. Typical carcinoids slightly earlier than the atypical carcinoids. And the typical carcinoids, as we all know, have a slightly better survival than the atypical carcinoids. They have a slight prevalence in women, and they are the most common primary lung neoplasm in children and late adolescents. And they can really occur anywhere in the lung. So in terms of how they present, so this is partly problematic. Just like many other cancers, they don't have a signature presentation. So the lung nets are often difficult to diagnose. They present non-specifically, and they can mimic other conditions, most often chest infections and bronchitis. So they present with fever and wheeze, chest discomfort, and about half the patients present with what we call hemoptysis, which is bleeding from the lung. If your cancer is peripherally located, so on the edges of the lung, then often these present as asymptomatic cancers, and the atypical carcinoids are well known to do this. If they are centrally located, then they will present with obstructive symptoms, and they may present slightly earlier because of the obstructive symptoms. But many patients, because of this nebulous presentation, they present late, and because of that, there may well be a price to pay in terms of curative surgical resection and the impact on survival. What's well documented are the syndromes in these cancers, in neuroendocrine cancers, but it's important to note that in neuroendocrine cancers of the lungs, syndromes are very rare, they're not very common. And the most common syndrome that we hear about is carcinoid syndrome, which is flushing, diarrhea, leaky heart valves. And that occurs, I've written 1 to 5% of cases, but actually in the latest data set, it's much lower than that. But that's not the only syndrome that can occur. They can also present with high levels of steroids, and we call that Cushing syndrome. They can present with high levels of growth hormone, we call that acromegaly, and they can occur with a pattern of tumors, and we call that MEN syndrome. But this is where things get tricky. It's when we start looking at the management of any cancer, and the lung neuroendocrine tumors, it's particularly tricky. So when we get a patient reporting of an illness and a preliminary diagnosis is made of a neuroendocrine tumor, then the first specialist that we have to switch on is the pathologist. And the pathologist, his job or her job is really to confirm the cancer. So the first thing they have to do is confirm that this is a lung neuroendocrine tumor, so a very rare cancer, versus very common cancers, so something else. Once they agree that this is a lung neuroendocrine tumor that we're dealing with, they then have to classify this cancer either as an atypical carcinoid or a typical. And then they have to tell us whether it's a secreting cancer or not. If it's something else, then the diagnosis goes down a different path. Once they've diagnosed it, then we have to switch the radiologists on. So the radiologists then have to tell us in a binary fashion, is this cancer, to the best of their knowledge, localized, or is this advanced? And the way they do that is by radiology, and unique to neuroendocrine tumors, we can also use quite a lot of nuclear medicine. And I'll explain what nuclear medicine is in later slides. So once we've established whether this is a local cancer or whether it's a cancer that has spread, we then come on to management. And this is where a whole raft of specialists are switched on, possibly too many specialists. And what we really need are those that treat this cancer in high volume to be switched on. And we really need to switch off the specialists that use this cancer as a hobby. But if this is a localized cancer, then the surgeon needs to step in and decide whether this is a resectable cancer. And if it's a resectable cancer, the first port of call, the primary indication is surgery. And if it's not, if the surgeon feels that it's not amenable to surgery, even though it's a localized cancer, then the oncologist has to be switched on, and they will then have to devise a non-surgical management for that cancer. If this is an advanced cancer, then it is firmly in the court of the oncologist, who then orchestrates the management. Really, this is in the arena of systemic treatment. But controversially, follow-up is probably the bit that needs sorting out first. So living beyond and living with cancer is actually very difficult. And many patients will tell me that. And so really, we still haven't worked out properly who takes responsibility and how they take responsibility for these conditions, especially the resected patients. And so I may come on to that later on as well. So I'm going to use prognosis to try and explain the difficulties we have in dealing with a cancer like this. So I'm not going to ask the audience what these pictures have in common. I'm going to give it away. So those that are of a biblical mind or of any Abrahamic religion will know that the first person is Methuselah. Methuselah was the grandfather to Noah. And Noah, his father, and Methuselah himself, what they had in their genes was longevity. The second diagram is a picture of the Methuselah tree. So this is a tree that exists in the United States of America. And we know that it is 5,600 years old and still living. So it has longevity in its genes. And then the final one is the most amazing one. That's the Methuselah star. So this star is about 17 billion years old. And we know that the universe, the Big Bang, occurred 13 billion years ago. So they really can't explain why this star is older than the Big Bang. What all of these have in common is longevity. And one of the things that is often presented when we come across neuroendocrine tumors is that these are long-lived cancers. But prognosis actually depends on multiple factors, which rely on really accurate diagnostics, really accurate staging, and really accurate treatments. And so it's not a given that these cancers are Methuselah cancers. And such things as histology and classification have to be done accurately. Staging and spread have to be looked at properly. Responses to treatment we have to pay attention to. And of course, the patient's well-being and history at presentation are extremely important in all of this. And I'm going to go through some of these factors and how they affect prognosis as I go through these, explaining how this cancer is managed. The first thing to start off with is the histology. This is really important. Okay, so cancers of the lung arising from the neuroendocrine tumors of the lung, there are 4 types. There are 2 that are well differentiated and 2 that are poorly differentiated. So the well differentiated neuroendocrine tumors are the typical and the atypical, grade 1, grade 2 respectively, and the poorly differentiated neuroendocrine tumors are the large cell and the small cell cancers. These are both classified as being grade 3. So what does differentiation mean? So I'm now going to step from being a theologian to being Darwinian. So this is the ascent of man. And the best way to explain differentiation is really using the ascent of man. So the normal man at the front of this queue is civilized, supposedly. And if you left him in your house, he'd hoover the house, he'd look after the house, clean the house, etc., obey laws, and wouldn't cause any disruption. And so we regard that, that's akin to normal tissue. The second person is slightly shorter, carries a weapon, and is Neanderthalic. And so, although will behave mostly, may not behave perfectly. And we call that a typical neuroendocrine tumour. So that's a grade 1 neuroendocrine tumour. The third person is a bit more ape-like, and that can be likened to the atypical neuroendocrine tumours. And the poorly differentiated cancers can be likened to early man, who certainly won't behave in a civilized manner, won't behave according to rules, etc., etc. And so this ape-like creature probably will cause the most disruption. And so that's akin to a grade 3 or a poorly differentiated neuroendocrine cancer. And I've left one, and so basically as we go from the upright man down to this ape-like creature, cancers get more and more aggressive. But of course, I've left this middleman out, and this is a new discovery that the academic society is still trying to work out. So we've called this a grade 3, so belongs to the poorly differentiated group, but well differentiated, so belongs to the grade 1 and grade 2 groups, a grade 3 well differentiated net. So these are tumors that sit in the middle, and they're still yet to be defined properly. But the most important thing is that as we go from well differentiated cancers to poorly differentiated cancers, the aggressiveness gets worse and the prognosis gets poorer. And so getting histology right is very important. And this is really down to the pathologist to make this call. And they will base their diagnosis on, firstly, the shape of the cancer. We call that morphology. Then the immunostaining of the cancer, what kind of special receptors the cancer has on its surface. And then on something called the mitotic index, or the Ki-67. And I'll attempt to explain these in the next 2 or 3 slides. Well, I'll try to explain it in this slide. So when the pathologist chooses whether this is a grade 1, grade 2, or a grade 3 neuroendocrine cancer, then it's up to them to classify the cancer. And so they'll use various parameters to try and classify it. So they'll use tumor differentiation. So I've just been through that. They'll use this thing called the mitotic count, and they'll use something, they'll look at whether the cancer is necrotic. Necrosis occurs if a cancer grows really quickly and doesn't have the ability to create a blood supply fast enough. And so part of the cancer will die. And so aggressive cancers tend to have necrosis. But this thing called the mitotic count is probably quite important. So currently, the Ki-67 score is not part of the neuroendocrine classification for lung nets, and that's a slightly sore point. So what is the mitotic index? Well, the mitotic index I've tried to illustrate in the circular diagram on the left. So if you take cells in a slide and you look at all the cells that have got visible chromosome in them, so DNA that's undergoing replication, and you divide by the total number of cells on that slide, then you get what we call the mitotic index. And clearly on this slide, I can tell you there are 10 dots. 4 of them have chromosomes visible, and therefore the mitotic index score is 40%. Okay, and so this is used as a measure of aggression. The less the mitotic index is, the better. The Ki-67 score I've illustrated on the right. So this is a short-lived protein, and you can see that when a mother tumor replicates, it creates daughter cells, and each daughter cell has a little bleb on its surface. We call that the MIB1, and we can use an antibody called Ki-67 to detect this little red blob. And the more daughter cells that have that bleb on it means that the more the cancer is undergoing reproduction, and therefore more aggressive. And so the Ki-67 score is often presented as a percentage, and a small cell cancer will have a Ki-67 score often greater than 80%. So 80% of the daughter cells are undergoing reproduction, whereas a typical neuroendocrine cancer will often have a score less than 1%. So not many of these daughter cells are undergoing reproduction. It's a matter of aggression. So once the pathologist has done his or her job, the next step is for us to then stage the cancer. So this is where we work out whether the cancer is localized, and we know that 70% of cases that present in the UK are localized. Mostly these are the typical cancers. 7 out of 8 of the cancers are typical. And nowadays we use gallium PET scans, and often these can upstage a small cohort of patients where we thought they were localized, but then we find disease that has spread. And so here we have a man who's got this neuroendocrine tumor in his lung, and you can see that here. And the surgeon will come along and resect it. But what we want to know, as people that are going to follow up patients that have had this resection, is what are the chances that this person is going to have what we call micrometastatic disease that isn't visible currently on a CT scan, but is sitting there seeding and waiting to grow. And we have clues. So we can use the histology. We know that atypical carcinoids are more likely to have this occurrence than typical carcinoids. When we are given the TNM, when we are given the pathology staging of a resected sample, we pay particular attention to the T stage and the N stage, the nodal stage, how many lymph nodes were removed and how many were positive. And we also pay attention to whether the surgeon removed the cancer completely, or in fact, there was some cancer they felt left, so an R1 resection. And there are currently other factors that we are investigating as prognostic factors. But clearly these micrometastatic deposits aren't visible on any scans that we have. And so we follow people up through time to see if they ever manifest themselves. If a cancer has spread, then we know that they have a predilection for the liver. And so people shouldn't be too concerned if the liver is involved, because that's usual. We have to make sure that the person doesn't have syndrome, but we have to also be cognizant of the fact that syndrome doesn't require the liver. In other neuroendocrine tumors, pancreas and small bowel, the liver is required before you can get syndrome. But in the lung, you don't need the liver. It can happen by itself. And then, of course, we want to work out, if we give the person treatment, what is the survival? What is the benefit to that patient of giving that person treatment? And to do that, we now have many new treatments. We know that we have better management of syndrome, and we have better follow-up. So all of these have improved the survival of patients. But for non-curative patients, we also have a risk of prognostic influences. And once again, histology plays an important part, but here, the wellness of the person plays a really important part. Syndrome or not, has the person got syndrome? We know that syndrome is a poor prognostic sign. How many organs are affected? We know that the liver is often affected, but how many other organs are affected? Importantly, response to therapy is important. And then there are other factors that we are currently exploring. So how do we accurately stage a person? Well, we know that in terms of patients that have had resection, typical carcinoids, typically 5 to 15% of these patients can relapse. Atypical carcinoids, it's much higher, unfortunately, and about 50% of patients can relapse. But it's important to know how they relapse. So about half the patients relapse to the liver, a quarter to the lung, and then a fifth each to lymph nodes and bone. And this is important because I've often gone around the country to see how people are applying management rules to neuroendocrine tumors. And sometimes I have come across some centers that only use chest x-rays because they want to save on radiation exposure for the patient. But actually, chest x-rays won't pick up on liver or lymph node or bone disease. And so we've worked very hard over the last 2 or 3 years to try and explain to centers around the country, not just to use chest x-rays. And in fact, the standard of care investigation is the contrast enhanced CT scan of the thorax, abdomen and pelvis to make sure you're not missing out on any relapse disease. And for those patients where you want to avoid too much radiation, then we can use MRI scans. But MRI scans do have limitations, especially in organs that move, such as the lung. We have another part of the armory that we can use, and that's nuclear medicine. And nuclear medicine will look not only at spread, but they will also look at function. And so there are two types of nuclear medicine scans: the PET scan. So the FDG PET scan is used largely for grade 3 tumors, but they are useful for grade 1 and grade 2 tumors. But the most important PET scan that we have nowadays is the gallium DOTA PET scan. And so this particular scan uses a marker, so kind of shown that here. So the gallium DOTA marker is this little yellow dot with the antibody underneath it, and that clings to the somatostatin receptor, which is shown as red on the surface of the blue cell, and the yellow bit, which is the gallium, the radioactive bit, that shines up, and we can detect that using the gallium PET scan. And that really has allowed us to pick up many more advanced patients than previously we'd known about. So we must always keep in mind the systemic nature of any cancer when we're staging patients. And that's just a general rule that oncologists apply. Never assume a cancer is localized until you're absolutely sure. So how do we manage these cancers? So the well-differentiated lung nets, general principles. Okay, so briefly in the next two slides, I'm going to cover surgery. So post-surgical follow-up is really important, and it's largely been ignored for many, many years, which is wrong. But there should be follow-up for many reasons. Mainly because early pickup does make a difference with this cancer. The only exceptions to patients that may not need follow-up are those that have a very early form of cancer, the T1A, N0, M0 cancers. But people that visit me at the Christie Hospital, they will know that I follow them up as well, because I really want to understand what the survival curves look like for even those patients. The other reason for following up is that living beyond cancer, as I said before, it needs support. It isn't easy. When the surgical bandwagon and the oncology bandwagon move away and leave the patient to their own devices, that can be daunting. And so just for that, we should follow up. But actually, one of the main reasons for me to follow up patients is the opportunity to develop real-world evidence for survival, for relapse patterns, and for quality of life patterns, so that we can understand for future patients how to better inform them. The atypical neuroendocrine tumors, or any neuroendocrine tumors that are associated with risk factors, and I've been through those risk factors in my previous slide, should be more intensely followed up. But you have to keep an eye on the amount of radiation you're exposing patients to. Follow-up needs to be for a long time. So one of the amateur mistakes that many hospitals make is they follow people up for 5 years. That 5-year figure is an economic figure that came from President Nixon in the 1970s to try and save money. Actually, for these cancers, if we know what the survival curves look like, really we should be following them up for 15 years. Patient reporting is the previously advocated method of follow-up, where patients report when they feel ill. But my argument with that is that by that time, often it's too late. It is just as important as clinic visits, so both need to be done together. And we've recently published UKNet's guidelines for all available clinicians to see what they should be doing, so there should be no excuse. So medical management, general principles again. Until recently, in lung nets, it was a huge unmet need. There were no licensed or commissioned medications specifically for lung neuroendocrine tumors, and you'll understand why in a second. And then more recently, this drug called everolimus came along and became the first licensed drug globally, which was also approved by NICE, our commissioning body. So when we see a patient, the first thing we need to do is control syndrome if the syndrome is there, and then we need to control the cancer. And there are certain principles. So maximal cytoreduction is still important. Having less tumor cells in your body remains important. Survival obviously remains important, but also quality of life remains important. So there are many, many treatments, but you'll discover shortly that they are really poorly studied. And this really needs to improve. And I think this is where patient groups could come in really helpful. So with pulmonary nets, I've already said the gross principle is if it's a functioning cancer, so a cancer that is exhibiting syndromic symptoms, so carcinoid syndrome, Cushing syndrome, you need to control that first. And then you need to control the cytotoxic element of that cancer. So the amount of cells, you need to reduce them in the body. So the general principles are control symptoms and then cytoreduce. The key message here is that controlling syndromes is really well evidenced. And so we know exactly what to do with patients that have syndrome. What we don't know what to do with particularly well is how to cytoreduce. And this is because it isn't a well evidenced speciality. So if you look at all the options that are available to us, and if you go around the country, and I've done a study called a LEAP study, which I'm briefly going to present, what I discovered was that there was no sequencing of treatments. It was awful around the country. People were using any method in any order. And that's problematic. And it's mainly problematic for people like me, but problematic for patients as well. Because if you take any rare cancer, if it's poorly evidenced, what you get is clinicians, as in this case, using multiple therapies for the same indication. If you do that, you get white noise in your efficacy signal. So you don't know what is truly working and what is just anecdote. And if you get that situation, you get confusion, and that breeds more anecdote. And if you allow that to happen, you get diminished academic interest. So the good people move away. That leads to reduced funding opportunities, and that leads to poor R&D and poor drugs coming into the arena. And that vicious cycle carries on, and it needs to be broken. And really the only way to break it is to have consistent practice. Consistent practice then protocolizes a single therapy for each indication, and that then starts to improve this vicious cycle. So you get a better signal, and suddenly you get more money, better people, and better management. And that's really where we need to go with this cancer. We need to protocolize everything, and then everybody needs to listen. And I'm going to illustrate some of this to you by looking at the evidence base for various modalities that some people may have been subjected to. So the key message, just so that you don't forget, is that the key to improvement of any outcomes is evidence base. So here is somatostatin analogues. Okay, so we know that there are two leaders in the market, octreotide and lanreotide. They do the same thing. They're slightly different, but they do the same thing. They control 80% of untreated carcinoid syndromes, so that's very good. And they have an indication in gastroenteropancreatic nets. Okay, where did they come about? Well, so they've been used for syndrome for a long time, but more recently we realized that actually they have a cytoreductive effect. So the blue line here, so these are survival curves of patients between 1973 and 1987 compared to 1988 to 2004. And you can see that in the early days, we weren't giving somatostatin analogues to everybody, and that is signified by the blue line. Then between 1988 and 2004, we started giving somatostatin analogues to more and more people. And suddenly the survival curve, the yellow line, it lifted. So we suddenly realized that actually there's probably a survival benefit to giving these drugs. And so we then sought primary, what we call phase 1 evidence. Okay, so grade 1 evidence rather. So we did two prospective studies, the PROMID and the Clarinet trial. And once again, they showed benefit. And because they showed benefit, the use of these two agents for cytoreducing patients was licensed. Unfortunately, lung nets were excluded from these trials. And so we tried to set up our own trial called the SPINETS trial, but we failed to recruit. So we got halfway through and then it failed to recruit. And that probably signifies a rare cancer, possibly that we're not as organized as we should be globally. And so I think we're now going to try and publish the SPINETS as it is. So regardless of that, there's a consensus agreement because there's good evidence, PROMID and Clarinet, the real world evidence, all good evidence. And so there was a consensus agreement that we should put that into our protocols. And so first line treatment we now accept is the somatostatin analogues. So that's good. Where it's not so good is chemotherapy. Okay, so lung neuroendocrine tumours have been poorly tested with chemotherapy. So as a result, there have been attempts to move away from cytotoxic treatments, but essentially, chemotherapies tend to work for poorly differentiated cancers that are quickly growing. These cancers are possibly not that type of phenotype. However, many treatments have been tried, but all the trials have been really poorly designed. They've had mixed histology, so they've mixed up the small cells with the large cells, with the typicals and the atypicals, which is not good practice. They've been retrospective, so they've been done in a backwards fashion. They've been poorly powered, so we haven't statistically taken good advice. They've not even had very good endpoints. So survival is a good endpoint, quality of life is a good endpoint, but these trials have used other endpoints because they've been unable to statistically have good endpoints. And often they have been non-randomized. So poor design in trials has resulted in poor evidence, and that has resulted in no consensus agreement in when chemotherapy should be used. It's the same story with immune therapies, and interferon tells a story. So until about five years ago, interferon was one of the standard of care treatments for this type of cancer. But you can see from this table, the trials were all tiny. They were single center. They all concluded very differently. And as a result, there was no consensus in agreement. And so this just died a death. We really didn't know what to do with interferon, which is a shame because it may have been useful. But a good example of evidence gaining is when we really globally get together and do something properly. And the Radiant trials and the Luna trial really show that actually the LungNet community is capable of doing this. So the story here is that the Radiant 2 trial was never designed for lung neuroendocrine tumours, but Novartis did this trial. They did include lung neuroendocrine tumours. They didn't exclude them. So 10% of the patients we discovered were lung neuroendocrine tumours. And when we did an exploratory analysis of the benefit of everolimus in the lung neuroendocrine tumours, we found a signal. We found that it could be useful. So the next trial, which is Radiant 4, we then planned to put lung neuroendocrine tumours in, and that was very good practice. And so a third of the patients in this trial were neuroendocrine tumours. And once again, we found a strong signal. And so then we did a trial just for lung neuroendocrine tumours, and we found a really good signal. And because of all that work, we got rewarded. So there was consensus agreement, and NICE approved this particular treatment for the use in lung neuroendocrine tumours. And that's really what we need to do for really all the modalities of treatment that we're using. And so the benefits you get from doing something properly is that in 2000, this was the type of drugs that were being offered to people trying to explore treatments for lung neuroendocrine tumours. In 2021, it increased. So that's good. So it's a carrot and stick. If we demonstrate that we can get organized, do large studies, then you get the funding and you get the opportunity to do many studies. And that's really where we need to improve in lung neuroendocrine tumours. And so we're still searching for evidence and a position and a role for PRRT therapy, radiotherapy, immuno-oncology, and chemotherapy. And I was asked especially to briefly talk about PRRT, so I will do. So PRRT in LungNet isn't yet established properly at all. So what is it? So this is basically targeted radiotherapy. You have a radioactive agent, so you can use either yttrium, Y, or you can use lutetium. So these emit radiation, and you can attach them to dotatate or dotaTOC, and these are proteins which bind to the somatostatin receptors. And when they bind to the somatostatin receptors, the lutetium or the yttrium can then poison the cell. Okay, so very targeted therapies. We know that the yttrium emits something called a beta emission, which is essentially an electron, but it has a short half-life, but it penetrates through tissue quite a lot. lutetium doesn't penetrate through tissue that much, and therefore lutetium is less toxic. And so in many countries, lutetium has been favored. And if you look at the lutetium studies, so this is one study, you can see that if you look at the progression-free survival, so the PFS, the progression-free survival, the time taken before a person progresses from treatment, and if you look at the median overall survival, the lung nets do the worst out of pancreas, small bowel, unknown primaries, and others. And possibly there is a reason for that, and it's a reason that we need to explore. 7 studies report survival using lutetium specifically for the lung neuroendocrine tumours, and they all report that the typical carcinoids do slightly better than the atypical carcinoids, which is no surprise, and they lend an advantage in PFS, progression-free survival, of about between 15 and 20 months, and they lend an overall survival advantage between 37 and 50 months. So there is a signal there. The trick is to get organized and do a proper global study, and there are some that are happening, but we just need to be more organized. So compounding that problem, so I was aware many years ago that there was possibly a postcode lottery in this country. So I got together with Professor Dennis Talbot in Oxford to explore that. So we interviewed about 30 centres around the country, Scotland, Ireland and England, so in the UK, and we did questionnaires to see what their management plans were. And what we found ultimately was that there was a huge variation in follow-up for resected patients, which was concerning. A high proportion of patients were just getting lost to follow-up. There was a large variation in whether to give adjuvant therapy or not. Large variation in diagnostic pathways. So some people had access to gallium scans, others didn't. And there was various treatment pathways that people were using different schedules, different sequencing, as I've illustrated in my previous slides. Most importantly, though, there's variation in access to experts, and this is a real problem. The access to specialists that see high volume neuroendocrine tumours of the lung is really important, and there are some parts of the country where this doesn't happen. So in summary, although the incidence is increasing, bronchial nets still remain rare, and rare cancers are often difficult to generate evidence for, but the cousins of bronchial nets, pancreatic nets and the GI nets, they've managed to get evidence, and therefore we need to manage to get evidence as well. Accurate diagnostics, classification are challenging, but fundamental, and we need experienced pathologists to get this. Staging needs appropriate radiological and nuclear medicine staging, and we need experienced radiologists to do this. Post-surgical follow-up is very important, and we need experienced clinicians, not hobbyists, to follow up these patients. This is really important because you get a feel for how people relapse, and that's important. Picking up relapse at an early point does make a difference, and so that's important. Developing our knowledge of outcomes and how these cancers behave in the future is really important to inform the next generation. And of course, supporting people who are trying to live beyond cancer is important. Medical management, it needs experienced oncologists, not hobbyists. Okay, there's a huge unmet need for evidence base, and we need to generate that evidence. We need to unify so that we can stop the postcode lottery. And the best way to do that currently is to actually generate real-world evidence. And the only way we can do that is by listening to protocols. And so I thought I'd end on this slide. So some of you may know what this picture is. So that dot in the screen is Earth. And this was when Voyager turned around at the end of our galaxy and took a picture of our Earth being basked in a ray of sunshine. So it really shows you how lonely the Earth actually is in space. And sometimes when you're a neuroendocrine physician, this is exactly how you feel. Specialists who look after neuroendocrine cancers aren't hired specifically to look after lung neuroendocrine tumours. It's way too rare a cancer. It's not a standalone disease group, so many people will have other specialities and other interests. So it may just be a hobby. For many years, it wasn't adopted by ENETs and UKNETs, and I think that was a mistake, but it is now. It only accounts for 1 to 2% of lung tumours, and so you can see how rare these cancers are. So many physicians don't know much about these things. But one of the main problems is there are multiple specialists looking after a small number of patients, and that really dilutes the specialist care. And somehow we need to stop that. And I think I would propose that we work together to initially reduce inequity. That's the first thing we need to do around the country. We really need to protocolize management. We need to educate everybody, not just clinicians, not just nurses and healthcare professionals, but also the patient. We need to empower the patient through knowledge so they know what is best for them. And the ultimate goal is, of course, experienced clinicians look after a very rare cancer. Thank you.